Hello everyone and welcome back to this full day-long study day talking everything long COVID. This is session 2 and this is based around research and what we need to know. As per the last session, you have to be signed into the YouTube channel to be able to access the chat box, but please do let us know where you're dialing in from, who you are, and of course any questions you want to ask this fabulous panel. Now the panel are very active on Twitter, so please do tweet them and use their Twitter handles, and especially if we don't get any questions answered. And I do have to mention again that we include people living with long COVID on the panel, so please just bear with us. If there's slight delays or particularly if there's any stumbles, we are all hardworking clinicians just trying to get the message out there. So I'm going to allow the panel to introduce themselves to start with, and then we're going to go straight into the first presentation. Asad, down to you first, please.
Hello, everyone. Thank you very much, Rachel, for the opportunity. My name is Asad Khan. I'm a consultant respiratory, sleep and long-term ventilation physician at Manchester University Hospitals. My base is Windsor Hospital. I'm also a long COVID sufferer living in month 5 at the moment.
Thank you. Anita, my co-chair.
So my name's Dr. Anita Atwell, and I am a proud and loud occupational therapist, and really very proud for AHPs to be involved in research, and really pleased that we've got this session to promote research with long COVID.
Thank you. And over to Charlotte, who's going to do our first presentation today. But Charlotte, just the words you said on one of our other podcasts, the only thing that will get us out of this pandemic, research and vaccines, and that has just stuck with me for months. So Charlotte, please introduce yourself and then go straight into the first presentation. Thank you.
So I'm Dr. Charlotte Summers, a physician and researcher at the University of Cambridge. And I'm just going to share my screen so that I can show you some slides. I'm hoping that you can see those okay. So today I'm just going to give you a really brief overview of an exciting clinical trial that we're about to launch. And hopefully we'll have our first sites open later this week, called Heal COVID. It's helping alleviate the longer term consequences of COVID-19. Now, it's an urgent public health national platform trial that is having tremendous support from the NIHR, who are our funders, and also by the CRN working with us to deliver this trial, hopefully at every hospital that admits patients with COVID in the NHS. So what's the problem? Well, the problem that we're trying to address is the fact that actually 1 in 3 patients who are discharged from hospital with COVID-19 are readmitted within 3 months. And 1 in 10 of them sadly die in that same time period. And 3 in 10 of them have developed new respiratory disease, and that should say 29% of patients. Somehow my 2 has disappeared with sharing my screen. So 1 in 3 patients readmitted, 1 in 10 patients die. 3 in 10 get new respiratory disease, and 1 in 20 get a new serious cardiac event, all in the first 3 or 4 months after leaving hospital with their COVID admission. So Heal COVID, what we were trying to do was to say, well, we spent a lot of time targeting research at the hospital phase and at this point also pre-hospital, because there's a thing called the Principal trial that read out this week showing that inhaled steroids stop you from getting admitted to hospital. But there was nobody targeting interventions at the kind of convalescent post-hospital phase of COVID. And we thought, well, the inflammation and all of the things that have caused you to be hospitalized don't just stop when you leave the door of the hospital. And actually, it's not acceptable for 1 in 3 people to get readmitted to hospital and 1 in 10 of them to die in the few months after they leave. So what can we do about that? So we've established a platform trial, very much in the model of the recovery trial that you'll have heard about, to try and provide evidence about what works and what doesn't, the therapies given in the post-hospital phase, to see if we can improve clinical outcomes. The aim is to see whether we can improve the amount of people who are alive and not in hospital in the first year after they have been discharged from hospital with their admission from COVID, but also to see about patient-reported outcomes and whether the interventions impact on those, and to use health economics to assess the cost effectiveness. Who are we targeting? Well, it's everyone who's over the age of 18, who's hospitalised and approaching the end of their hospital admission, because we're going to recruit them when they're ready to leave hospital. And they have to have had SARS-CoV infection associated disease for that hospital admission. So their positive test needs to be for that hospital admission rather than someone who's already been readmitted. How are we doing it? Well, the current treatments are, we're going to recruit you when you're ready to leave hospital. You will go home and either have standard care or 2 weeks of apixaban, which is an oral anticoagulant, or a year of atorvastatin, or on our third arm, we're just in discussion with the UK COVID Therapeutics Advisory Panel about what that should be at the moment. And we're going to follow you up for a year using digital technology, so there will be no hospital visits, no clinic appointments, nothing as part of the trial. You'll be able to tell us how you're doing via your smartphones or the internet or a nurse phoning you, and we'll be able to get the primary endpoint from the study via NHS digital and health records. So it's got a really minimal burden for the participants. People will be randomised, which is the really important thing to find out whether these therapies actually work. And what are we measuring? So we're measuring hospital-free survival at 1 year. We're also measuring the components of that, so mortality and readmission, serious adverse events, cost effectiveness, but also a load of patient-reported outcomes, because these are really important to understanding whether these therapies are impacting on people's experience. So we're measuring fatigue, we're measuring breathlessness, we're measuring an outcome measure for recovery, which captures things such as how are you doing, are you getting back to occupational employment that you were before, or a modification of that. We're looking at some mental health and well-being scores, your overall quality of life, how tolerable you find the intervention you've got, and then some specific systemic symptoms. It's been really difficult because there are no validated, at the moment, patient-reported outcomes specifically for coronavirus infection or for COVID. So we've had to do some patient engagement exercises to work out what's meaningful with our patient advisors. The follow-up, so you're discharged from hospital with your therapy. All of the follow-up is remote, so you don't have to leave your house for it if you don't feel up to it. And at 12 months, it's the end of your study participation. If you want to find out more, and I really hope you do, because we really want every hospital in the UK to sign up to this, and so far we've got about 90 hospitals that are keen, you can get hold of us at trial.team@healcovid.net, or our Twitter feed, which is @heal_COVID, and the trial website, which is just going live. You can see some of the content, but not everything as yet. https://www.heal-covid.net. And now I am going to share with you a video from some researchers who are looking at patient-reported outcomes and community COVID, so people who've never required to come to hospital with their COVID, from Birmingham, who were not able to be here in person this morning. So I'm just going to press play and hope this works.
Hello everyone, my name is Lee Aibasi. I'm a research fellow and a deputy director at the Center for Patient-Reported Outcomes Research, University of Birmingham. Today I'll be talking about the TLC project on behalf of the TLC study group. The TLC project has various work packages, but the main idea behind these work packages is to, first of all, leverage the existing infrastructure, which would help us understand the disease or the condition in this case, which is the long COVID, and also help us to provide enough evidence that would accelerate the development of interventions, with the ultimate goal of benefiting patients with long COVID and the society as a whole. In work package 1, we intend to set up the cohorts for this study. And this would be done by using data from the Clinical Practice Research Data Link, from which we would identify individuals that have had a diagnosis of COVID-19 at least 12 weeks before, and we would also match controls with these people. We would then invite the patients or the individuals with long COVID that we've identified from this record to report their symptoms and their quality of life using a digital platform that has been developed by the Pathology company. Work package 2 would involve the characterization and immunology of long COVID. So in this work package, we intend to characterize long COVID syndromes, and we will do this by cluster analysis using machine learning, which would help us identify distinct syndromes within COVID, long COVID. We already know that in COVID itself, some clusters have been identified, so we want to do the same for long COVID. And then individuals from each cluster will be invited to provide the samples, which will be blood or saliva, which we would use to measure things such as inflammatory markers, antibodies, and T-cell function. And this will further help us with the characterization of these clusters. The individuals would also be provided wearable devices, which will help us to collect data on things such as the heart rate, the physical activity, and sleep. Again, this would help us to identify the potential therapies that can be recommended for each cluster of patients. Work package 3 would look more closely at therapies itself. So we would review existing interventions, especially those that have been used in previous post-viral syndromes, and also the ones that are currently being developed for long COVID. And would hope to be in a position to identify which interventions are best suited to each cluster of long COVID that we identified from the previous work package. And the aim is to provide an evidence base for recommendations on which pharmacological and supportive therapies can be recommended for specific syndromes in long COVID. Within this work package, we also hope to hold some workshops where there'll be consensus and there'll be co-production with all the relevant stakeholders so that we can develop a virtual intervention going forward. Work package 4, which is the final work package, will look at conducting feasibility study of the virtual intervention that we have developed. As part of this, we'd also want to find out if it's cost effective or not. So in summary, that's my presentation about the TLC study. I would like to thank the various collaborators on this project, including the University Hospital, Pathology, CPRD, and the University of Birmingham. And also not forgetting all the patient groups that are working with us, including the Long COVID SOS group and other support groups out there. Thank you very much.
Thank you so much, Charlotte, and for showing the video. We are going to move swiftly on to our next speaker, Dr. Asad Khan, who is going to tell us a little bit about his and his team's experience up in the Northwest. Thank you so much.
Thank you very much, Rachel, for the invitation. Sorry, I'm just getting a bit of echo here. Okay, yes, so I am in my 5th month of long COVID at the moment. I'm going to tell my story. It is by no means the worst long COVID patient story that you would have heard. I think I have done well compared to a lot of people in accessing healthcare. I tell this not for sympathy, but I tell this because patients are really not getting what they need. And this is hopefully a cry for help on their behalf. So I am a respiratory consultant of 12 years standing now. Since the first peak, I have been doing frontline COVID work, with my specialty being ventilation. That includes aerosol generating procedures. Standard PPE was a surgical mask and apron for COVID positive patients unless they were AGP, and that is in line with the PHE and WHO guidance. I also have elevated cholesterol, allergic rhinosinusitis and arthritic knees, and a background of an overactive bladder. I have depression. I'm very open about my mental health. It's treated and it's stable, and it has never impacted on my ability to carry out my job. I haven't had a day off work due to it. And I was actually in charge of junior doctor well-being and management right from the first peak. And clearly that was quite a challenging role during the pandemic. And was a gym attender 3 times a week, married to a GP, and have 2 primary school children, one of whom is neurodiverse. So that is a challenge in itself. I'm just going to try and move this along. So my acute COVID was quite unremarkable. I had a slight temperature, I was very sleepy, I had transient myalgia and quite crippling nausea. I would not have taken the criteria for testing at the time, but I was, shall I say, creative with booking the test and tested positive. I had a month of work, mainly due to fatigue, and went back just for some desk duties. 3 days, it was Christmas week, and felt I could manage. But Christmas weekend, it was as if I had, the only way I can describe it, walked into a wall of new confusing symptoms. So I was confused, I was drowsy. It honestly felt like my whole body was on fire, but I didn't have a recordable temperature. I had chest pain, I had palpitations, I was desaturating down to the low 90s. I had pain in absolutely every joint. I was going to the toilet every 10 minutes, including overnight, and it was really painful. And I started with new rashes involving the head and the neck. I thought my COVID was over. And at that point, I didn't know much about long COVID. So I actually thought a lot of the symptoms were in my head. That is a picture of me. Those are not the worst rashes, but you can clearly see on the right-hand side, I have some wheals there, sorry, some hives there, and on the left-hand side, I have angioedema of the left eyelid, and this was extremely painful. And it honestly felt like it was just burning all the time. I was on quadruple dose antihistamines, which did very little. I remember going out into the snow for relief because nothing else would work. And they drove me to distraction. At one point, I felt like I could not cope with them anymore. I also noted that my previously healthy baseline heart rate had shifted from 70 to the low 100s, and it would go up further every time I stood up. And I'm convinced that at times I had flutter because it was 150 for prolonged periods. I had intermittent chest pain that was very hard to describe. And I do have a lot of sympathy for patients now who struggle to give a history. It honestly felt like I just couldn't take a deep enough breath. My cognition was impaired. I was making errors with my own medication, but also with my son's medication, and I had to stop handling that. I ended up in hospital 3 times, largely with chest pain and desaturation. And even though my saturations were 94%, which is within the normal range, I think it's worthwhile remembering that that was not normal for me. So be careful when you see a normal value that's in the low normal range. Steroids were magic. My symptoms just disappeared with that, but clearly that was not a sustainable option. I had my first vaccine in February, and since then I have had constant autonomic symptoms, coat hanger sensation in my chest, constant nausea, and crippling fatigue. I'm not one of the lucky 1/3 who have improved after the vaccine. This group saved my sanity and possibly my life. I came across them on the recommendation of a colleague. It's a group of doctors who either have long COVID or who are interested in the condition and want to help. and I obtained most of the recommendations for treatment from the experience within this group. And they had to really fight hard because in the first peak, there was very little testing and even less awareness of long COVID. My experience of healthcare so far, I have a wonderful GP who listens and engages and works in partnership with me. Most treatments that I've had have been derived from the long COVID doctors group, which I will then discuss with my GP, who will then come up with a plan using that information. But she is actually quite firm when she needs to be. I didn't want to go into hospital because I was afraid of being dismissed on one occasion, but she made me go in. My department at work are extremely supportive, and I think I'm quite lucky in that respect. I know that other people have had poorer experiences. I did find that to get specialist investigations and opinions, I had to rely a lot on my own contacts and my knowledge of the system, and it worries me about what lay people might have to go through. There were some very hurtful comments from some specialists and colleagues, attributing it all to stress or burnout, saying I was tired, advising me to be thankful that I was alive, but also imposing their thinking that because I was stressed, perhaps I was over-perceiving my symptoms. I was certainly not doing that. When I took the research I'd done or suggested investigations and treatments to some of these specialists, I was constantly met with not constantly, but mostly met with refusal and lack of engagement. That's unlikely. There's no evidence. Nobody knows what to do with long COVID. You're only a patient, and you need to remember that. It made me realize that medicine is still quite a paternalistic and particularly Western medicine reductionist approach. And maybe it was the insecurity of these clinicians that they projected onto me and labeled me as anxious. Maybe they felt threatened that they didn't know and were afraid to admit this. In fact, I've been moved out of one service because the therapeutic relationship completely broke down. It's exhausting enough being ill, but actually on top of that, researching treatments, justifying that you're ill, and navigating your way through the system is just crippling. And one of the specialists actually recognized that and said, you're collapsing under the weight of being your own doctor. Let me take some of that burden off you. And since then, he has taken a lot of the responsibility of coordinating my care. One of the issues was that there was very little out there in terms of guidance for investigation and treatment. So we are all aware of the NICE guidance that came out in December. But if you look at the section on management, that is all you get. I checked this last night. This self-management, multidisciplinary rehab, and a small section on support for older people and children. There is nothing there about how you investigate and treat people with symptoms of organ involvement. And this was fed back by the doctors group later on, in that it was really not representing the patient experience and wasn't really a useful guideline. And this is just drawn from the doctors' long COVID group. You can see there's a huge range of pathology that people have suffered from. This information is in the public domain. So apart from the cardiac complications, a lot of people have dysautonomia, which is very, very hard to diagnose and often takes years to be picked up. Late pulmonary complications, spinal cord problems, other neurological problems, endocrine, hepatic, and may I add to that also encephalitis, which has been recently described, which was untreated for weeks and weeks and has only recently been picked up. So quite disabling and quite physical symptoms. It was on the back of that we thought that there was a gap. This is a study in preprint at the moment that a number of us contributed to. I was not one of the main authors, so don't expect to see my name right up there, but I did contribute. 29 of the 33 contributors were long COVID sufferers, and 5 were involved in service development for long COVID clinics. And the basis of this was that we can't assume that this is solely post-viral fatigue and that rehab alone is sufficient treatment because there's clearly organ damage and excess death in acute COVID. And it would make sense that you see a similar picture in long COVID. And we felt that as expert physician patients, as in those with the condition and involved in developing services, we had a lot to share. And with all due respect, other experts probably were going to have a narrower view limited to their own specialism. And I have to say, it's very practical, it's very commonsensical. Maybe that is what its downfall is. It says that long COVID clinics should be led by a doctor with a broader view of long COVID, and it's important to look for the physical pathology first, and the other therapies such as psychological support and rehab have to be adjuncts to that. And it's inappropriate for long COVID clinics to be led by mental health specialists because there is the worry that end organ damage might be missed. And there are some practical recommendations for investigation and treatment around looking for chronic pulmonary emboli, the importance of cardiac MR in looking for myocarditis, how to manage mast cell disorder with higher doses of antihistamines, how to advise people with cardiac symptoms or dysautonomia to pace themselves and to exercise, and how to treat dysautonomia when it is identified. And there are some very simple measures that have been suggested in the guideline that, if people were aware of, could be very easily recommended to patients. We felt that because a lot of these treatments are quite benign, it would be very sad if we denied patients these treatments when they are suffering so much. This is a session on research. It was one of the gaps in my CV. I was never a big researcher, and I can't wait for the proper research on treatments to come out, but we can't wait until then to treat our patients because at the very least they need some investigations and they need symptomatic management. However, this paper has been rejected by the BMJ because we didn't consult the right experts, apparently. I'd love to know who they are. If you find one, please let me know. I would like to talk to them. And the Lancet has rejected it as well. As clinicians assessing long COVID, what can you do? I think recognizing that patients do bring a wealth of experience. For now, the priority has to be listening to them. And it's okay to know, so it's okay to not know, sorry, typo there, not know what is wrong, and it's okay to say that. You will not be diminished in the eyes of your patient by admitting that. But at the very least, acknowledge that the suffering is real and show a bit of empathy. You have to think in terms of possibilities, not probabilities. So think about more possibilities than you might normally when you're faced with a patient, and offer symptomatic treatment. Saying that somebody just has a sinus tachycardia when they're batting along at 130, 140 is not acceptable. They need slowing down because it's really distressing. And we have to accept that patients may know more than us and that a lot of that information will be derived from support groups, and some of it is worth considering. So form a partnership with your patients. A lot of the tests are normal, so a lot of the basic blood screens or CRPs are normal. That does not mean it is in your head. It means that the test just didn't capture what was going on, and one needs to look harder. And please stop labeling patients as anxious just because you don't know what's going on. If patients appear frustrated, that's because they're worried about their illness and they're exhausted navigating the system. As my friend Clarina says, since when did anxiety become the commonest cause of unexplained tachycardia in the middle of a pandemic with a new virus? If your patient is fatigued, please do not recommend graded exercise therapy and CBT in those who are getting post-exertional malaise and dysautonomic features. And I was sorry to hear the other day that some long COVID clinics are still recommending this. This needs to be managed very, very carefully along the lines of chronic fatigue syndrome and ME fatigue. So now, after a lot of hard work, I have a number of diagnoses. I have post-viral urticaria. I think I might have mast cell activation syndrome, but some of my specialists disagree, and I'm on monthly immunosuppression. I have dysautonomia with an inappropriate sinus tachy with a POTS phenotype. I couldn't tolerate beta blockers because they gave me bronchospasm, and I'm now in ivabradine, which seems to be helping. I have involvement with the bladder, which wakes me up 4 to 5 times a night, and I have stress incontinence every time I go. I have small airways disease, which is probably post-viral, and I'm awaiting repeat investigations. Luckily, a cardiac MR excluded myocarditis, but I do have clinical pericarditis, which is resolving, and I take colchicine for that. Started with pain in the small joints of my right hand, which is under investigation. I have short-term memory problems and sensory overload. So that is quite intrusive into daily life. I have complications of steroid use. My weight's gone up 10 kg, and I now am pre-diabetic as well. I remain off work, and recently I got a letter saying I was clinically extremely vulnerable, which is probably secondary to the immunosuppression. The episodic nature of symptoms has been emphasized, and that is so true. I can walk and pick my son up from school a kilometer away some days, but some days I just spend most of the time in bed. Due to my cognitive issues and due to the episodic nature of the symptoms, I don't feel it's safe to work. My employer so far has been very supportive, but a lot of people have had to be off for 1 year, and when I go back, I worry about the 4-week phased return and what happens after I exhaust my 1 year of COVID pay. I don't think that's been tested yet in salaried healthcare professionals, but I do know that in GP land, a lot of people have lost their jobs. I can drive short distances. I still need 1 or 2 naps a day, otherwise I get malaise. For me, it is very frustrating not to be able to participate in childcare or housework the way I did before. I was very hands-on. I am not fasting this Ramadan due to the need for fluid intake and medication, and that's quite devastating. It's the first time in my adult life. I have made my way onto the local long COVID steering group, and that's been a very fruitful partnership, and I think that's been able to affect some change in the way the clinics are run. There is a lot of anger because of pandemic mismanagement. Let's be honest, it was a dog's breakfast. I lived in New Zealand between 2014 and 2018, and I wish I'd never returned. And the PP guidance from PHE about a virus that we knew very little about was just inexcusable. Countries that have had proper PPE have not had the same rates of health worker death and COVID infection that we have had. I should not have got COVID from work in November. It is not my employer's fault. It's the fault of the guidelines from PHE. And obviously the gaslighting from colleagues and specialists has been very hard to deal with. Initially, there was a lot of guilt. I felt I should be at the coalface looking after these patients, but now I am more accepting of the fact that my health has to be my priority, and I'm looking at work as one part of my life for when I go back, not just my life. I'm all for budesonide. I'd love to see a recommendation around that, and I also think it's a scandal that there hasn't been a proper large-scale RCT of vitamin D because it's cheap and cheerful and would benefit. As has already been said, prevention is key. There are new variants, and there has been vaccine escape in Chile, which has 100% vaccination rates nearly, and is now in the midst of a surge like no other. And I was on a podcast with David Nabarro, who's a UN envoy on COVID, and he's convinced that we will see a third wave in the UK and that the vaccine will not necessarily be protective. It would help if it was recognized as an occupational illness for frontline workers. It would ameliorate a lot of the sadness and the anger that we feel. When I say frontline workers, I don't just mean healthcare workers. That includes policemen, delivery drivers, teachers. And that's it. Thank you for your attention.
Well, thank you so much. That was just, there is so many comments, and there's no questions for you because it's just thanks and praise for your presentation. But Anita is going to come in a second because I've just got one very quick question for Charlotte. So Charlotte, it is about, let me just find it, sorry, my messages are, it was about assessing is any plans to include patient-reported functioning disability in your study?
So we've got a range of patient-reported outcomes that we're collecting as part of the study. one of the compromises we had to make is not to place too heavy a burden on people, because we're going to be asking them repeatedly over time. So we committed that we would not ask more than 10 minutes of questions once a week. And that's something that we've worked with some long COVID sufferers to make sure that actually that the 10 minutes is 10 minutes with people who are struggling with their cognition at the time they're doing it, as opposed to 10 minutes of someone who's whizzing through it. So we've had to limit what we're collecting, but we are collecting health-related quality of life, some performance status measures about are you where you were when you were healthy before, how far towards that have you moved, have you returned to the employment you were doing before, and some very general measures of function, as well as things about fatigue and breathlessness. So it's not everything that everybody would ever want us to collect, but equally we cannot put that kind of burden on people who are struggling with their recovery, which is the really important thing. What they don't want is 5 hours in front of a TV screen or in a clinic appointment being asked a series of questions. So we've tried to strike a balance. So we know it's not perfect, but it's about the best we could come to in collaboration and co-development with patients.
Thank you. Over to you, Anita.
Thank you. Asad, I wanted to say thank you particularly for your presentation. I actually found myself becoming very emotional during your presentation. Don't know how everyone else felt about it, because I felt all our training is about the lived experience, is about listening, empowering service users, and it's evident that we've got a lot to learn and a lot of work to do around validating what people actually say and not dismissing it. So I think that's a key take-home message to all AHPs and everybody that's listening today, is about the patient experience. But secondly, I think what's really come for me is that all research has to be co-produced and patient-led. And I think what's really, really essential from today is not to make up your own research question because you think this is research, but actually go to the COVID patient groups, go to your service users, go to those people and actually ask them, does this matter to you? Is this important? Is this the right thing that we should actually be researching? And I think time spent doing that means that we're going to get the right research, because it's no good doing research for the sake of doing research. Let's do research because this is what long COVID persons actually want. There's people all around us. There are mothers, our brothers, our sisters with long COVID at the moment. So if there's one take-home message, do research that matters. Don't do research because you think it's important.
Couldn't agree more.
I would say that matters not just for long COVID, but for all our research. Actually, something we've been really bad in across the whole of the research piece, isn't it? Is putting patients at the forefront and embedded and co-producing every bit of research we do. If we were to only do that for long COVID, and we should, we wouldn't have learned anything from this pandemic, would we?
I can't believe how that session has just come together. I think in my head I hadn't appreciated that, and that's massively down to you, Charlotte, and you, Asad. So thank you so much. And Anita, your comments at the end, I couldn't have surmised those comments. So everyone's on social media, please reach out. Asad, you're going to have lots of comments coming through after this, I think, for sure. And Charlotte, people are already directed to the study. So everyone, we will be joining back in 5 minutes. So please go and get whatever you need to get and be back here in 5 minute quick break. Thank you so much.